said माने एकच कंपनीचे
Yes, I am there.
तो एमसी सर को आता है मराठी अच्छा
सर के साथ अकेले मैं गुजराती में बात करती हूँ अदरवाइज आई डोंट हैव एनीबडी टू स्पीक माय मदर टंग हियर इन सोलापुर आल्सो
Yes.
So the program is now live streaming.
Yes, ma'am.
So it's exactly 6. So if you think
Shreya, can you please ask?
We will start.
Shreya, can you please ask Santosh Madam to join so that because she's the chairperson for the first session, no?
Okay, sure.
Yeah.
Santosh Chandak.
So, welcome to the 199th edition of Happy Learning Masterclass webinar series with Aurangabad, Hingoli, Jalna, Osmanabad and Parbhani Obstetric Gynec Societies. Welcome, and we start the program by prayers to the divine and then we take it forward from there.
वक्रतुंड महाकाय सूर्यकोटि समप्रभा निर्विघ्नं कुरु मे देवा सर्वकार्येषु सर्वदा
With that prayer, requesting
Yes, ma'am.
Dr. Monica. Yeah.
Welcome to the 199th episode of the Happy Learning series, and I'm sure each one in India has been a part of it sometime or the other. Heartiest congratulations to M.C.Patel sir for the dedication to the same, and I always take privilege to introduce Dr. Asha Jain Madam, who is the convener of this series. She is the director of the SMSA Hospital, Raipur. She is the medical director of CPRS, which is an NGO which works with cervical cancer prevention. She's an elected member of the Governing Council, Medical Council, a zonal chair, Foxy Food, Drug and MSc Committee, West Zone. She is also the chairman of the Mission Pink Health IMA, Raipur, an executive member of ISCCP, the Governing Council member of ESAR, and of the Society of Fetal Medicine. She has held various positions, including the presidential post of Raipur OBGYN Society, vice president of IMA, president of the Rotary Club of Raipur North. She has her centers which are recognized for ultrasound and colposcopy. She is academically also very strong, and she has been trained in colposcopy, as well as she holds a fetal medicine and obstetric ultrasound F certified. She's a sonologist, which is certified. Her fields of interest include saving the uterus, fetal medicine, obstetric and gynec ultrasound, critical care, and preventive oncology. We welcome you, ma'am, as the convener of this program. Ma'am, please unmute yourself.
Okay.
Yes,
Asha, you are muted. Please unmute.
Okay. Thank you, Dr. Monica, for doing the honors. And now I would like to introduce Dr. Monica and Dr. Rekha Rajendrakumar, who are the two coordinators for this program. So Dr. Monica Umbardand, this is her own forum. She's known to everyone, but she's a consultant obstetrician gynecologist at Mangalya Nursing Home and Atharva Fertility Center.
Ma'am, that should be all right, ma'am.
Amogs. Welcome so much, Monica.
Thank you so much,
very active Foxian and is ready to coordinate any webinar that we need. Then our second coordinator today is Dr. Rekha Rajendrakumar ma'am, who's the president of Bangalore Society, an ever smiling, happy face. She has a lot of academic accolades, but right now she is handling a huge society wonderfully, doing a very good fem care conference. And she has been practicing for 32 years, has many awards, felicitations, has 17 awards, 7 felicitations. Welcome, Dr. Rekha.
Yeah, thank
Now,
you.
I would like to invite Dr. M.C.Patel, sir, to give his welcome address. We all know Dr. M.C.Patel, sir, whose brainchild this program is. We are at 199 and we are going to be 200 very soon. And sir is very consistent with his programs, doing the work very regularly. We appear as conveners and coordinators, but actually it's not just us. Sir prepares the entire program and hands it over to us so that we can finally do it. So he gives a lot of time. He knows most Foxians and he's going for president this year. Welcome, sir. Over to you.
Thank you, Dr. Asha. It gives me immense pleasure to welcome you all on 199th episode of Happy Learning Masterclass. And today's joining society, Aurangabad, Hingoli, Jalna, Osmanabad, and Parbhani. I welcome Dr. Rajendra Singh Pardeshi, good friend, and we have worked in Foxy for years together. He is always kind to me for any of my academic activity, to encourage me, to help me. And today he has kindly consented to be chief guest to bless the webinar. Welcome, Dr. Rajendra Singh Pardeshi. I also welcome Dr. Ajay Mane. When I started this series, first Dr. Rajendra Singh Pardeshi told me that you involve Ajay in your academic activity. And I had a phone call to Ajay. And straight away he said yes. And he was with me in this series more than 1 year. So Ajay is also a good old friend. He has kindly consented to be guest of honor to bless the webinar. So welcome, Ajay. I also welcome 2 learned speakers. So first speaker, Dr. Dipti Vaidya madam from BEAD. She is going to discuss very interesting topic, approach to AUB. And to chair that very interesting session, Dr. Lalita Bajaj madam from Aurangabad, Dr.Krishna Pawar from Parbhani, and Dr.Santosh Chandak madam from Parbhani. They are going to chair that very session. And second session would be panel. The panel is reverse panel and it is on legal issues in labor and high-risk pregnancy. So panelists will be asking and being a moderator, I will be answering. So to invite and to welcome all the learned panelists, Dr. Lalita Swami madam from Osmanabad, Dr. Shreya Chandak madam from Parbhani, Dr.Rupali Gaikwad from Aurangabad, Dr.Ashwini Kubade madam from Parbhani, Dr.Sunita Khedkar from Aurangabad, Dr. Anil Kainade sir from Jalna, Dr. Vijay Sindebhau from Jalna, Dr. Anuradha Garad from Osmanabad, Dr. Vaishali Gaikwad for Aurangabad, and Dr. Senur Dandodwarkar from Hingoli, and Dr. Shraddha Paritkar from Aurangabad. And one more interesting topic we are going to discuss, and Dr. Vinayak Khedkar is going to discuss that very topic. So welcome, Dr. Vinayak. Vinubhai is my good old friend, and we have worked in Foxy for years together, and he was always kind to me in any of my activity. Vinubhai, welcome. And to chair that very interesting session, I welcome 3 learned chairpersons, Dr. Parveen Palla madam from Osmanabad, Dr. Purnima Yande madam from BEAD, and Dr.Aparna Raul from Aurangabad. I also welcome Dr. Asha Jain. She is convener in this series since long, past president, Raipur OB/GYN Society, and a coordinator, Dr. Monica Umbardand from Solapur. Monica has remained instrumental in our webinar series in Maharashtra. She has helped me a lot in each and every webinar, not only execution, but designing and inviting faculties, etc. She has helped me a lot. So thank you, Monica, for the same. I also
Thank you.
welcome Dr. Rekha Rajendrakumar, one more coordinator from Bengaluru. She is President Bengaluru Society. And all the President and Secretary of Joining Society and all the delegates who have joined this webinar, I welcome you all on 199th episode of Happy Learning Masterclass web series. When we started this series in era of COVID-19, I started and I invited 2-3 more friends and we started this series. Aim was to meet our Foxian friends on virtual ground to discuss focus topic, to discuss medico-legal topic related to that very topic, and to say hello. It was our aim. But with blessings of all seniors and help and guidance from all friends, this series has continued and it has reached 199th episode. And today also we are going to discuss very important clinical topic which are useful in our day-to-day practice. So I would thank all the dignitaries who have joined this webinar today and all the seniors, friends, and well-wishers who have helped me to run this series till 199, and still it is continued, of course. So without wasting much of your time, thank you very much.
Thank you, sir. Thank you so much. Now we start the inaugural session, and it's my pleasure to introduce Dr. Rajendra Singh Pardeshi, sir. He was the
It's
past
okay.
president
It's okay,
of
Asha.
AMOGS.
Asha, it's
Yes, sir.
okay. It's okay. We can skip that. So, good evening,
So we
everybody.
are delighted to have you here.
Good evening, everybody. Respected guest of honor and Vice President, Dr. Ajay Mane, sir, Program Director and past VP, Dr. M.C.Patel, sir, Convener, Dr. Asha Jain, Coordinator, Dr. Monica Umbardand, and Dr. Rekha Rajendrakumar. As Dr. M.C.Patel told, it's absolutely right. Dr. Asha Jain and Dr. Monica Umbardand, and they are continuously running this happy learning program. So congratulations to both of them. And now I joined Dr. Rekha Rajendrakumar from Bangalore. She is also very active. First, I wish to congratulate all Aurangabad, Hingoli, Jalna, Osmanabad and Parbhani societies for their active participation in this webinar on AUB and legal issues in labor. I'm feeling proud to be a part of this program with my AMOGS members. All are there, so it's a homely environment with Dr. Lalita Swami, Dr.Shreya Chandak, Dr.Rupali Gaikwad, Dr.Ashwini Kubade, Dr.Sunita Khedkar, Dr. Anil Kande, Vijay Shinde, Anuradha Garad, Vaishali Gaikwad, Sonali Damkondwar, Shraddha Paritkar, Parveen Palla, Purnima Yande, Aparna Raul, Vinayak Khedkar, Dipti Vaidya, and our Aurangabad President, Dr. Lalita Bajaj, Krishna Pawar, Santosh Chandak. I think with the involvement of all and the learned speakers, I think this is going to be a great event. So I wish every success to Dr. M.C.Patel, sir, our program director. And this Happy Learning is a brainchild of Dr. M.C.Patel, sir. So I wish every success to him for his future endeavor in Foxy, as he's contesting for the post of President of Foxy in this forthcoming election. Same thing, I wish every success to Dr. Asha Jain for her future endeavor in Foxy, as she's contesting for the post of Chairperson of Food and Drugs Committee. That Food and Drugs Committee is very close to my heart. So I wish every success to Dr. Asha. So wishing every success to this webinar. I don't want to be in between you and the scientific content. Thank you. Thank you so much for inviting me. Thank you. Thank you, MC sir.
Thank you. Thank you, Rajendra Singh Pardeshi. You are always kind to me in any of my activity, just I told prior also. So thank you for sparing time to bless the webinar. Thank you.
We are with you only, sir.
Thank you. Thank you.
Thank you so much, sir, for gracing the occasion. Ma'am, Ajay sir is in traffic. He will join in another 5 minutes, ma'am.
No issue. We
So
can.
should we introduce him and then we can,
Yes, we can continue accordingly, and when he joins, we will have blessings from him.
Yes.
Okay. So, Dr. Rekha, would you like to take this? You are
Yeah,
muted.
I will take, we will, as M.C.Patel sir said, we will take blessings of Dr. Ajay Mane once he joins. Now let me have the pleasant task of inviting Dr. Ajay Mane. Sir is the Vice President of FOXI 2024. He is a member of National Inspection and Monitoring Committee PCPNDT Wing, Government of India through FOXI, medical legal consultant, as all of us know that he's been doing for past more than 2 decades. He's a chairperson of the official AMOX website 2018 to 20, and again for next 2 years later on, chairperson of Sexual Medicine Committee of FOXI also, again chairperson of Adolescent Health Education Committee of AMOX. He was the past president of Aurangabad OB-GYN Society, ex-superintendent of MGM Medical College, Aurangabad, health advisor of Sports Authority of India, and chartered president of Rotary Club of Aurangabad, alike. So we are very happy to have Dr. Ajay Mane, and we will continue with the program. Meanwhile, I wish all the success to M.C.Patel sir and Dr. Asha Jain.
Thank you so much. Thank you so much, Dr. Rekha. Thank you for that introduction. And
Yeah.
we'll keep our eyes open. As soon as Mane sir joins, we will take his blessings.
Ma'am, sir is here.
Yeah. Dr. Ajay
welcome,
Mane,
sir.
we just introduced you.
Should I
We just
stop
introduced you and yeah.
Welcome, sir.
Yes, welcome Ajay Bhau.
Sir ji, namaste.
Namaste, बस स्वागत है.
I'm so sorry that I got late due to traffic.
You are at right
time.
time.
You are perfectly in time, sir.
Okay. Thank you, Monica ji.
Sir, please proceed.
So I'm here to express my gratitude to my mentor in medical legal field, Dr. M.C.Patel sir, my mentor in my real life, Dr. Rajendra Singh Pardeshi sir, my elder sister Asha ji, and my younger sister Monica ji, and Rekha ji, and all others. Pranam. ये 2019 अक्टूबर-नवंबर में M.C.Patel sir and myself we have started the happy learning series. Means 5 साल हो गए उस series को, and meanwhile we have shared knowledge to everybody, all the corners of the India. Everybody got benefited from this by academic means, by political means. M.C.Patel sir can express that. But the aim of this series is to give knowledge to the proper persons at their hometown. Those who cannot attend the conferences, those who cannot attend the CMEs, those who cannot attend the webinar, seminars. So for them, this is a very good platform. And since 5 years, M.C.Patel sir is consistently doing this. So I appreciate the work by the great personality, M.C.Patel sir, and I wish him all the best for his endeavor in the FOXI, and I wish Asha sir to aane wale or Asha ji also to have her great success this year in the FOXI. I request everybody to help them go in the FOXI. So thank you very much. Thank you, Patel sir. Thank you, Asha ji. Thank you, Monica ji, for calling me here. Thank you very much.
Thank you, Ajay, for sparing time. And you have nicely remembered when we started this series, just before you joined, I was telling that Dr. Pardeshi sir told me that you involve Ajay in this series. And I had a phone call to you, and straightway you said yes, and you joined with me, and we started this series. And still we are continuing, and this is 199th episode. You will be happiest person, I would say, because you were one of them when we started this series. Thank you, Ajay.
Thank you, sir. Thank you very much.
Thank you so much, sir. So now we take the program forward. Thank you so much, Pardeshi sir. Thank you, Mane sir, for being with us. And now I would like to introduce Dr. Lalita Bajaj, ma'am. She is a practicing obstetrician and gynecologist at Ganga Hospital, Sambhaji Nagar since the last 25 years. She is also the president of Aurangabad Gynec Society. She was previously the secretary. She is an active member of Aurangabad Gynec Society and has given talks in many CMEs. Her interests are high-risk obstetrics. Dr. Monica, this is
Yes,
for you.
ma'am. Dr. Krishna Pawar, sir, is currently the secretary of Parbhani OBGYN Society, and he is a consultant at Ashok Hospital, Parbhani. Ma'am, he is in the OT. He'll join in another 10 minutes. Ma'am, should I introduce Chandak Madam also?
Yes.
Yes. Dr. Chandak Madam is the director of Chandak Hospital at Parbhani since last 37 years. And she is currently the president of the Parbhani OBGYN Society. We welcome you, ma'am, as a chairperson for this session. And we would like to introduce Dipti Madam, ma'am, as a speaker for this session, ma'am.
Hello, am I audible, ma'am?
Yes, ma'am.
Yes, ma'am.
Yes.
So, good evening, everybody. Now, I will
Ma'am,
like
could you
to
put
introduce-
on your video?
Hey, just a minute, ma'am.
Hello?
Yes. Yes, it's okay. Yeah, Dr. Dipti Vaidya, she is fellow in IVF endoscopy, ex-consultant Global Hospital, Baroda. Ma'am, I cannot see the CV here. She is ex-consultant Global Hospital, Baroda, ex-lecturer MGM College, Aurangabad, and consultant Anand Hospital and Bijanpur IVF Center. Experience of 13 years, faculty, MRCOG, and local and state level conference. Welcome, Dr. Dipti Vaidya, ma'am.
Thank you so much.
Ma'am, please, you can.
Yeah.
Dr. Dipti has a problem in sharing, so I will just see if I can download and I will share. Just give me half a minute and you can have a
Yeah, sure.
conversation on the topic till then.
Sure. I'm just
Okay, file. What she has shared with.
Dipti, can you share the PPT directly? Because what you have shared is your drive link.
I'm sharing it, but it's not. नहीं रहा वो.
Dipti, send it on mail. Send it on mail of Monica ma'am or maybe Asha ji.
That is what, sir. Actually, her Wi-Fi is too slow, so she cannot even mail.
It's
That's why she had said it from her
not
phone, sir.
compressing fast enough.
Pardon, Dr. Dipti, she told something.
No, it's not compressing to send on mail. So I have it on my mail, but it won't share the screen.
Okay.
Yeah, I think
So are you able to share? Listen, are you able to share it from your PC with your
my
computer?
video won't start from the PC. That's the issue.
Okay.
It's done. I'm sharing it. Just a second.
Okay.
Took a little bit of time, but it got
No
done.
problem. Actually, I was trying since 5:30,
Is
but
that
then.
fine? Is that fine?
Yeah, sure.
Yeah, we can see that.
So you can just say next and I will do it.
Yeah, sure.
Yeah, great.
So thank you so much for the help and a very good evening to all my seniors. Well, the topic that Monica has given me is a huge one, so I'll try to make maximum justice to it in the given stipulated time. So we are going to share on how we handle AUB. Well, it's a day in and day out thing. It's not much that is unknown about this topic, and most of me manage more AUB than the routines because of the vast experience that we carry. So we start from a very basic small tidbits, and then I'll finally take you to what the latest research on the percentage of various options that we have and how it is going to help us choose. So it was a broad term to start with irregularities in the menstrual cycle, in the duration, frequency, the volume, and slowly we had FIGO in 2011 and 18, which gave us, we dissolved all these different terminologies of oligomenorrhea, dysmenorrhea, and polymenses and all those things. And we got a standard classification of Palm-Cohen. Till then, we had it as dysfunction uterine bleeding, which we would take as the diagnosis of exclusion, obviously ruling out the organic causes. But now we include the organic as well as the non-structural causes in this. Later on, they added an intermenstrual bleeding in it, which defines that we take 75th centile of whatever is the defined problem that the patient has, which gives even more quantitative definition to it, because it's a relative term. Menorrhagia for one person may not be menorrhagia for the other. And that's how they do not present to us sometimes, even in the worst of the cases, and they do present even in the minuscule ones. So they have defined it to the theory of relativity, calling 75 centile as the ones where we need to act upon. Initially, we had acute and chronic, which still refers to. So chronic means anything which lasts more than 6 months or 6 cycles for that particular person. So what do we have in Palm-Cohen? The PALM, mnemonic, is for all the organic issues: polyp, adenomyosis, leiomyoma, and malignancy or hyperplasia in the PALM part. And the Cohen, which includes coagulopathy, ovulatory dysfunction, endometrial disorders, iatrogenic, and the not otherwise specified. So the not otherwise specified one, next slide, ma'am. Ma'am, you can take the next slide. The not otherwise specified includes basically the endometritis, the infective pathologies like pelvic inflammatory disease, and certain other comorbid conditions which will contribute to disorganized bleeding. Here, we also include cervicitis and chronic liver disease, AV malformation as well, and myometrial hyperplasia. Now, this is basically a sonological term. It doesn't mean anything clinically, but it gives rise to abnormal bleeding because of the chunk of the myometrium, which behaves in a desired manner. Next slide. So when we handle these patients, the epidemiology is a huge array of 3 to 30%, and the most common comes during the early and the late, the beginning and the end of the reproductive period of a lady. In the middle, usually peripartum or immediate postpartum are the most common places, or a post-abortal also, but these are all short-term disorders. And the most ones which last are either these two on the extreme ends. So how do we define the pathophysiology? The basic idea of handling an abnormal uterine bleeding is to go to the crux of what is the basic disorder that is underlying this. And as soon as we pinpoint the disorder, it's very easy for us to pick the options. So the very first is the uterine structural derangement, which will include all of PALM. Then comes the abnormal vasculature, where even malignancy or AV malformations can function. The most common that we encounter that is in a perimenopausal age are estrogen and progesterone abnormalities, which also involves HPO axis disruption, where we can include thyroid and prolactin disorders. However, we have hematological problems also, like the disruption of clotting pathways and endocrinological dysfunction, which in addition to these two can give a contributory 1 plus 1, 2, having two or more factors involved. Now, we all do history and physical examination very routinely. So I won't go into details of what we should and what we not examine in history and history taking. I'm very sure all the seniors are more masters than me in finding out the etiological factor. But yes, the most common pinpoint that we find out in incidence is associated endocrinological picture, like thyroid or maybe diabetes or obesity, where hyperandrogenism or hyperestrogenism comes into picture on a very severe grade. For example, hyperinsulinic PCO or an obese PCO. Also, we have in extremes of age where comorbid conditions are more. A lot of people have associated medicines that they take, where statins are there, anticoagulants are there, or someone with a heart disease, where there are on regular basis some coagulatory, wars and all such things which are there. In the physical examination, the only aim is we want to rule out the organic lesions and find out structural associations if there are any. So, which includes a basic pelvic examination and the ultrasound. So, how do we go out evaluation? When we see that we have either we divide them into two types of patients, one where we can find out a definable organic cause, and the other where we don't have a definable organic cause, and then we have to rule for other associative conditions which may be along with both of these. So the very first and basic thing which everyone of us has handy with us is an ultrasound, which will help us to find out whether it's an organic or an anorganic cause. If it's a non-structural cause, then a hormonal disarray will be very, very easily evident on the ultrasound. It could be an ovarian factor, a uterine factor, an endometrial factor, and there are multiple ways of finding out and ruling out to see where our definition belongs with the patient. Sometimes we do need MRI as well. We have, in case of endometriosis, subtle endometriosis, or clinically advanced, where we need to find out, especially in patients who need to have fertility preservation. Adenomyosis is one such which has varied array of presentation. In the most subtle cases, it can just present with dysmenorrhea, and then MRI will be the best pick. Of course, an ultrasound will be too late to show where almost there is global involvement or one patch, one wall involvement. A 3D ultrasound in these cases would be a better choice in case we suspect and we don't see on our routine gray scan. Myomas and malignancies, well, myomas in MRI only indicated, well, there are multiple myomas, we need a fertility preserving surgery, and she needs to go for future treatment post myomectomy. Or we need to, it's a gray zone size where we need to define whether we have a medical management on hand or we need to go for surgical. Malignancies in case of endometrial hyperplasias or obvious malignancies where we see on ultrasound and we need to define or grade them. Here I would say that sometimes in postmenopausal females, we often see that they have just leukorrhea and there is a cavity type of lesion which we can see on ultrasound, or we fail to see a thin pencil line endometrium. This, according to NCBI in the latest 23 study, is also a trigger where they say that either you go for MRI to see the enhancement picture and the disruption of endomyometrial junction, where we can see that where it's a beginning of endometrial malignancy, or along with that we can also use this for grading. Obviously, if we don't find or we have an office hysteroscopy on hand, as subtle endometrial lesions are always very easy to find on endometrial problems. Office hysteroscopy is also obviously useful because we can take an EB sampling. A lot of EB curates are available to do immediately in the OPD itself. If not, and if we really suspect that there is a pinpoint lesion where we need to see, then we can always post the patient, see and treat is what we believe when we have a lot of suspicion, but none of the tests or investigations are supportive. With this, we need certain blood tests where basic anemia evaluation, if it's an heavy bleeding disorder or TFT, HbA1c many a times is seen to be abnormal, whereas the fasting post meal is okay. And through this, I would not say it a dictum, but in my experience, I've seen a lot many times where only it's the HbA1c which is faltering and the others which are not. And then these patients typically present with endometrial hyperplasia, and they more belong to the category of PCO, which has a huge grade, where they have severe disorders right from a young age of onset of menarche, and they continue to present with heavy bleeding off and on. And an HbA1c or a fasting insulin here will give us a very good idea of how to treat these patients. A coag panel and a prolactin, where we see more of associated medications or obvious drugs which they would involve a faltering of the PTINR, and the other von Willebrand factor here is only warranted for puberty patients who present with first or second periods with abnormally heavy bleeding and where we suspect an obvious cause of hematological disturbance. A last paper in the last 2 years has also shown vitamin B12 and D deficiency to be associated with abnormal menstrual bleeding. Here, none of the picture, neither the ultrasound nor the other test will show abnormal. Just a raised MCV in the CBC should be enough for us to investigate vitamin B12 and D along with it should go. As soon as we start treating these patients with only B&D supplements, 90% of their problem is solved. But most of these also have underlying pernicious anemia, and so a peripheral smear or a hematological consultation would help us to rule out these two. Now, after the primary evaluation, we would grade these patients into the PALM-COAM system that we have. So what is the option that we have on hand, which is what it comes down to? So if it's an acute bleeding episode, we all know we can resort to hormonal progesterone or nocipil in tapering doses. To get support, we can use tranexamic acid, rarely an injectable testosterone if it's a huge bleed which is exhausting patients out of hemoglobin reserves. Additional coagulopathy we need to address, either a von Willebrand factor if it is really a cumbersome pointer, or a PTINR and APTT which shows us abnormality. Here we can take help of our hematological experts, and the dilatation curettage, especially this helps sometimes in defaulters who keep changing doctors and keep jumping to medications on and off on their own. So sometimes I've seen that patients end up not responding to any drug because the whole schedule that the doctor has given is broken, and this is very, very common, especially in fidgety patients who feel that they are done with their bleeding episode, so they stop drugs, and finally it confuses us on what to give because all the options have already been exhausted. So a DNC with aided histopathology would help. Now, I would take one by one on polyp. Polyp is a very easy to treat. Dissection is the easiest way. If we don't have an hysteroscopy, it's a small polyp, we can simply do DNC and send it for histopathology. A hysteroscopy guided polyp is very, very important in case it is a perimenopausal bleed. The polyp shows very high echo and raised PI value, sorry, not RI, which would warrant that the polyp needs a thorough histopathological investigation, especially if they carry comorbid condition which favors estrogen excess. Adenomyosis usually needs any drug which has anti-estrogenic properties. So an anti-estrogenic progesterone. Optionally, we can also go for Mirena. SERMs or GnRH analog, selective estrogen antagonists are only a sandwich therapy or a short-term therapy. According to papers, it doesn't prove very helpful in treating these patients on long term because it gives rise to a lot of ovarian cysts, which is an incidence of almost 30%, which again will give rise to abnormal menstrual patterns. So, least the better. A GnRH analog is better if we want to have a fertility preserving surgery. And finally, operative if the patient is past her parity period and is of a perimenopausal age group, then there's no need for trying the other methods. I remember a line which I've seen and quoted in many papers. Anybody who is perimenopausal showing all of these dysfunctions with a lot of anemia is already showing underlying that even if the history is short, she's already got into a compromise. So is warranted for hysterectomy, especially in case of adenomyosis and fibroids, which have huge recurrence, especially in the later part of the reproductive period. When we come to leiomyoma, we have loads of medical options now. Mifepristone, we have ulipristal acetate, we have GnRH, Mirena also in small fibroids. Myomectomy, where we have as a fertility preserving surgery, and the hysterectomy because we see that as an incidence after 5 years of removing a myoma, there is bound to be another small myoma which is going to come. So we respect the age and the parity and then decide of whether to opt for hysterectomy or not. Otherwise, GnRH would only be a pre-treatment option. Myomectomy again a pre-treatment option. Pre-treatment as in a fertility enhancing option to say. Mirena in these cases works very good for those fibroids which are less than 2 centimeters and they do not destroy the cavity. And of course, where there is associated adenomyosis also, then this is the best pick. As far as ulipristal and mifepristone, they are very short-term best, only used for not more than 2 to 3 months because they usually work by the method of liquefying the myoma and it stays there and it resolves after a period of at least 6 months. So only if there are symptoms are very mild and we don't really need to go for a surgical option, it's not that bad, but incidentally found, then we can give a short trial of these two drugs, not more do we need them. When we have malignancy or hyperplasia as a picture, then obviously surgery and appropriate grading as the FIGO guidelines would give us. Now, for coagulopathies is very easy. We just need to find out which factor is gone and which factor has dropped, and we need to replace it. We can use tranexamic acid only as an aid till the time to control bleeding and by time for finding out which factor needs to get supplemented. Many times it's seen that I would again remind that B12 and D deficiency enhance the disorder of blood clotting, and many times it's seen that borderline anemia with more of B and D deficiency do present as abnormal bleeding, heavy bleeding per se, with regular cycles which does not resolve on any hormonal therapy, as in it recurs. It's just a temporary treatment that the patient feels they have got. They are not very happy because they recur, and the routine original cause of injectable deficiency has not been corrected per se. Ovulatory dysfunction is what we see very commonly in the peak reproductive period. The short-term presentation is only found peri-abortal or peri-delivery, but the long-term ovulatory dysfunction is the actual problem, where it belongs to androgenic PCO or severe PCO who has a lot of LH, and that LH disturbs her complete pattern. Either she has long spells of amenorrhea and heavy bleedings, or she is completely amenorrheic and she does not stop bleeding once she gets a withdrawal or she is asked to get a withdrawal. So here, lifestyle modification, underlying cabergoline if we find out prolactin associated, and ENP treatment according to the imbalance found. Very commonly we see that short-term ovulatory dysfunction, as in a luteal phase defect or a short cycle, is very easily replaced with progesterone or a sequential ENP treatment, and the patient responds very fast within a span of 2-3 months, and there is no recurrence. The only recurring problems are the ones which have an androgenic proportion more in their bodies, or an excess of estrogen, and the disarray is very chronic and severe. And most of this is either diabetic, obese, hyperinsulinic, or PCO. So their lifestyle modification and maybe a help of myoinositol or metformin or insulin sensitizers would be much better and help than the other options. Endometrial disorders per se don't have any specific treatment because there is no pathophysiological understanding. The tranexamic or NSAIDs, or these are only temporary measures of controlling the bleeding, as long as we get to the definitive diagnosis, and then we need to properly address, as in if it's an endometrial polyp or and hyperplasia, or sometimes many diabetics show a picture of echogenic endometrium when their sugars go out of balance. If you sequentially follow them on ultrasound without doing anything, I mean, not doing anything in the sense, just correcting their diabetes and not intervening as far as the endometrium is concerned, and slowly we will see that as soon as the insulin and the sugar levels drop down, this picture on the ultrasound resolves and the patient becomes comfortable. So the HbA1c and the insulin is more I would say a problem here than the endometrium per se, because it is made to behave disturbingly because of the underlying hormonal disarray. Iatrogenic is again very easy. Find out the offending drug, remove it, and remove it or substitute it with some other thing which will not hamper the endometrium, and the patient will be fine. Endometritis just needs antibiotic, and for AVM we only have uterine artery embolization, and not much needs to be done. Often I've seen that patients report with AVM post abortal, where obviously an AVM is seen because they have just aborted and the patient becomes anxious, they need uterine artery embolization and so on and so forth. But many times if you wait for the post abortal or the post puerperial period to complete, then a spontaneous resolution of smaller AVM is very easy to observe and has been supported in papers. We don't need to do just watchful observation and seeing whether it is really disturbing the patient in the form of bleeding and then taking an action. Otherwise, embolization works wonders for these patients. So what do we achieve when we are looking at these patients? The main goal is achieving quality of life, fertility preservation where we need them, ruling out malignancy, which is the most detrimental, which should not be missed. And I'm very sure everybody knows and is thoroughly updated on how we need to, follow our suspicion and rule it out before we console and put the patient at ease. A comorbidity check is very, very important, or not missing out. A lot of patients forget giving history, and in the rush, they remember later on after they leave our consulting rooms, and then the lack of medication then shows and they suffer. So a comorbidity check for especially more than 40 is where we see associated clinical conditions arising there. Ocipils and progesterones are I would say only a temporary for an acute disorder. Not much needs to be done. Long-term management really is not needed if we find out what has gone wrong. Usually, auto correction of 3 to 4 cycles the body observes, unless there is a severe disarray, which is only in a particular endocrinological disorder where endocrinological screen.
Dr. Dipti,
Daddy,
you
you're
got
on mute.
muted. You got muted. Dr. Dipti, you got muted.
Please unmute yourself and talk.
And press on. Just 1 minute.
Yeah, you unmuted now. Go ahead.
Yeah. Okay. SOMs, although they show of contraception, but because they have an incurrence of ovarian cysts to a very high percentage, so routinely using them would be like putting the patient on double-edged sword.
You've muted yourself again. Dr. Dipti, you have muted yourself again.
Please unmute yourself, Dipti.
Dr. Dipti.
Next time, what I'll take,
You need to unmute yourself, Dipti. Ma'am, wait, I'll just call her.
Yes, what I'll take next time.
Yeah, she is not
She's going
listening.
on talking.
Endometrial ablation
Yeah.
was tried upon and was advocated before 5 years, but like for those who have biopsy showing negative and menorrhagia, we can use an endometrial or a TCRE, and a lot was advocated before Mirena came into picture. But slowly we realized that it destroys the basal layer. So if there is any estrogen excess that the patient has in the body, or a source of estrogen excess, then an ablation is a big no for this kind of patient, because we will spoil the surveillance of this patient. And more than 5 years, if she is on a progressive pathophysiology, then her whole detection will be masked, and then she will probably land up later on where malignancy has already shown up. LNG IUD is a very good option where there is no obvious cause. The patient may be in high risk for surgery, a myoma with less than 3 centimeters without any cavity distortion, or an associated endometriosis, especially rectovaginal. It works very good for such patients. And these many a times are PCOs who need fertility preservation. Of course, they have associated focal or global adenomyosis to some extent pre-IVF. And it is observed that cost, quality of life versus on follow-up, when we see the incidence of treatment failure for all these above causes is only 10%. This is after a pro rata analysis of 5 to 8 years of quality of life. Long-term outcome in these patients is very good, and they would opt out of hysterectomy, especially if they fall in the gray zone of 35 to maybe 40-42. For others, if it is a little bit advanced,
how much time remains, Dr. Dipti? How much
LNG IUD,
remains?
I have LNG IUD works for like Mirena works for 5 years, and we can replace and reinsert it.
No,
also,
how much of your lecture remains? We are running short of time.
no, it's just the last 1 or 2 slides.
Okay.
For hyperplasia, I've already said an office hysteroscopy, a good sonohysterogram, an MRI, and a perimenopausal screening. And if we don't find, and if we still are not very satisfied with blind sampling, we can always go for hysteroscopy directed biopsy and an MRI to help us. The endometrial hyperplasia, I've already elaborated in the previous slide only. we need only a routine endometrial surveillance for those patients where we see that not much has been found out in spite of doing histopath. And if they regress on their symptoms as well as on the ultrasound, then we only need routine surveillance of the endometrial behavior. Otherwise, if we see atypia, only there a regular surveillance of according to the histopathological type that we get. We can have a 3-monthly or a 6-monthly surveillance. And if we see progression, we can start treating them accordingly, because the risk of progression here is more than a simple or a hyperplasia or a basic hyperplasia without atypia. So on and on, the aim of treatment is just choosing an anti-estrogenic. Anti-progestins are also available, but not much has been found out through papers of how successful these medications are. And finding the correct source of estrogen excess and ruling out malignancy and choosing our options pinpointly and correctly would help us solve the issues better. So with this, I close my talk. Polyps and leiomyoma, I think I've already discussed. So I would not take too much time and repeat again. I hope
Thank
I've
you,
covered
Dr.
the max of what I could through this. Monica, you always give me long topics. But anyways, hope I made justice. Thank you so
Yes,
much for
definitely.
all your patient hearing.
I would request Santosh ma'am, Lalita Bajaj madam, and Krishna sir to please give their expert comments, as both of them have also joined.
Yes. Thank you, Dipti ma'am. You really put a very huge topic very compactly.
Thank you so much, ma'am.
Yes, AUB is a really very long topic. It is difficult to cover in 30 minutes or what, but you have explained everything nicely, right from the causes and then management. Management also varies according to pubertal, reproductive age, postmenopausal, perimenopausal. So you have covered very nicely everything. Very happy, always happy to listen you. You have
Thank
came
you, my
at
pleasure.
also.
Thank you so much.
In conference also you used to come and very nicely.
Thank you so much, ma'am.
Thank you, Lalita ma'am. Krishna sir, over to you. So,
Dr. Dipti, you did very well. Fantastically covered all short bullet points and well explained and well compiled. And in spite of that, explained in detail. Thank you.
Thank you very much, ma'am.
You can speak. I think sir's audio is on because sir was in the OT. Are you there, sir?
Hello.
Asha ma'am, we can move. Yes, sir.
Is there, Dr. Krishna?
Yes.
Yes, sir.
Sorry, madam. I was joined late. It was very nice lecture, and thank you very much. And you can continue now.
Asha ma'am, the first session I think is over now. We can move on to the panel discussion.
Excuse me.
Yes, sir.
My topic is also on AUB, and that is management and HRT. So, in fact, Dr. Dipti has covered so nicely the management part also. So I can finish it off within 15 minutes. The saline features, and then we can start with the panel rather than taking the management of AUB after the panel.
What does Dr. M.C.Patel sir say with sir's permission? Monica?
Patel sir?
Patel sir? Can't see sir.
Ma'am, I'll just give him a call for 1 minute.
Yeah. Vinayak sir, 1 minute, please allow us to call.
Sure.
Sorry to, yes.
No, it's fine. It's okay. Anyway, in the meantime, I can just say to Dr. Dipti, she has covered wonderfully. And actually, immediately when she went to the management part, I changed my presentation. I went back to my old presentation, and which will just cover, this is my topic, AUB treatment and HRT. So I'll be just covering the salient points and the basic principles of the management. That's the reason I was saying I'll just.
I think, sir, you go ahead. Okay. Because if you're going to take just 15 minutes, we might as well get it over, and then we'll have a relaxed panel.
Ma'am, I spoke to MC Patel, sir. We can continue with the lecture also.
Yeah, thank you. Thank you.
Okay,
Thank you.
so
Thank you.
Rekha, Dr. Rekha, over to you
Yeah.
now.
Yeah, okay, fine. Thank you. Can I have the CVs?
It's here. This is all we have.
Yeah, that's all. Huh? Okay, fine. Yeah,
Yeah.
thank you. It's the last, the second talk, and I request the chairpersons to chair the sessions. Dr. Parveen Palla, madam. Madam is the secretary of the Osmanabad OB-Gynec Society. We welcome you, madam. Dr. Purnima Yande, madam is another chairperson, and thank you, madam, for obliging and listening to our request. We are happy to have you here. She's a consulting obstetrician and gynecologist, MBBS DGO, and director of the Sri Kripalu Hospital in Bid. Her professional affiliations are she's member of PCPNDT committee, secretary of OBG Bid Society, and she's interested in serving high-risk pregnancy patients as well as cosmetic gynecology is her another interest. Welcome, Purnima, madam. Again, another chairperson is Dr. Aparna Raul, madam. She's practicing for 2.5 decades. She runs Aurangabad International IVF Center and infertility training at Badminder and I don't know that, Germany. Secretary of Aurangabad Society in 2005, held various posts in society, president of AOGS, that's Aurangabad Society from 2023 to 24, chairperson free paper in ASOG 2005, and managed 800 papers in 16 halls successfully. And she has received the Young Gynecologist Awardee in AOFOG Malaysia in 1919, ISAR Young Achiever Award in 2024, and her hobbies are many with a few like painting. She's a semi-classical music. She's been learning semi-classical music for past 7 years and running a fashion chain and Padmas since 3 years. So you have got varieties of hobbies and interests. Thank you. I welcome all the 3 chairpersons. I request to take the procedure forward. And Dr. Vinayak sir is going to speak on management of AUB. Request the chairpersons to take the
Parveen ma'am? Yes. Yes, ma'am. Actually, Purnima madam is in her flight, and Aparna madam is joining in 2 minutes. So you can start introducing with that.
Parveen madam, you can take the proceedings.
They will bring.
Parveen madam?
Yes, yes.
Yeah. Can we have CV of Vinayak sir?
Yeah, but yes.
Sharing. I was supposed to do it.
Yeah. Fine, no problem.
Hello, everyone. I'm happy to introduce Dr. Vinayak Khedkar, sir. He's a his UG and PG is from KEM Hospital, Mumbai. He's a private practitioner since last 27 years. His area of interest are high-risk pregnancy and infertility. He's a past practical obstetric committee chairperson, POXI 2012 to 2014. He was past president and secretary of AOGS. He was organizer secretary of AMOX 2009. Past peer surveillance POXI journal, member of Young Talent Search Committee, Food and Drug, Adolescent Health and Imaging and HIV committees. His hobbies are acting, singing, traveling, and yoga. This is for Khedkar sir. Please start your lecture.
Thanks a lot, Dr. Parveen madam, the chairperson. And at the same time, I'd like to say thanks to Dr. M.C.Patel sir, our medical legal mentor and advisor since long, and Dr. Asha Ji and Dr. Rekha Ji, Dr. Monica for inviting me here. It's my great honor, and I'll start my lecture without wasting much of time. I'll share. Yeah. My slide is visible.
You have to make it full screen, sir. It's visible, sir. You need to make it full screen.
It's full screen on my...
No, sir. Here below. Sir, did you share it after making it full screen?
Okay, I'll share again.
So you need to stop sharing and don't make it full screen before you share.
Okay. I'll make it full screen. Yeah.
Yes, sir. Yes, sir. Right. This 70% is written next to it. You have to touch that.
Yeah. Can you see now?
No, sir.
More, you need to click on the slideshow button, which is on the right side. Close to 70%. There are 3 buttons. The extreme right button, sir. I just. We can see your slides. Otherwise, also, sir, we can at least start with the presentation.
Slideshow. Resume slideshow.
Yes, sir.
Yes.
Can you see my CV slide now?
No.
No, sir. The slides are not moving.
Heading slide is seen.
No.
Abnormal uterine bleeding.
रस्तू दे कंटिन्यू करा चालेल
स्लाइड शो पर क्लिक किया तो नहीं आएंगी क्या?
I'll just share something different now.
So you want to send it to me, Vinayak sir?
I'll try now. Is it?
Yeah.
Now it is full screen also,
Yes.
sir, and now your CV is also same, sir.
Okay. That's not moving from my side now.
Sir, you click on this slide only once. Then you keep moving. Next.
It's moved. Okay, good. Thank God. Sorry for wasting the time, precious one. And I'll just go quickly over the topic because Dr. Dipti Madam has covered very nicely the management part also. That was my topic, but it's good. All over the world, AUB is almost 11% women are affected, and in India, almost 18% women are affected. And by the time they reach 36 to 40, the percentage rises to 36%. So burden of heavy menstrual bleeding in India is almost 42 before 21 age, and after that it rises to 53% of all OPD visits. In fact, most of the patients what we get are because of DUB, and all majority chunk of surgeries are hysterectomies. In fact, one of my friend used to call that like the only indication for hysterectomy is the presence of uterus. Obviously, because of that approach, government had to take some stringent initiatives and stop. And these lectures are going to help all these doctors to decide that hysterectomy is not the only option. Although AUB impacts up to 30% of women at some time in their life, this is the impact. It reduces the quality of life, and over 60% of women, they land up in for hysterectomy within 5 years. And out of them, 1/3 they land up in removing the anatomically normal uterus. So what is abnormal uterine bleeding? As per the ACOG guideline, any bleeding from the uterine corpus is abnormal in regulatory volume, frequency, duration, or occurs in absence of pregnancy. There is nice guideline also, and there is a figure definition also that any bleeding except for pregnancy which is sufficient in volume so as to make the treating clinician require urgent or emergent intervention. And chronically is any AUB present for the previous 6 months. So then there is a palm coin classification, which is the used one nowadays. Dr. Dipti Madam has already covered this, so I won't go in details. Main thing is in the management, that is evaluation. How will you evaluate is using the palm coin classification. And the history is very important to decide the whether the how are the cycles when they are started, how is the heavy bleeding. Then any concomitant medications like antidepressant, anticoagulants are there. PV examination is very much necessary, although we are forgetting because of the TBS, but it's going to help you decide the uterine size, the flexibility, any associated fibroids or masses. And then investigations like laboratory investigations, imaging, the specialized test, and the endometrial examinations. In history, one should ask for any history of PPH or bleeding so as to decide whether are there any coagulopathies. And then you can do the coagulopathy screen. and the hematological tests accordingly. And the imaging, you are supposed to do ultrasound. In fact, that is the most important non-invasive test which is available bedside for us. You can do the Doppler sonography also for suspected AV malformation and differentiate fibroid and adenomyosis. You can do the 3D sonography and saline infusion sonography if the hysteroscopy is not available. MRI to decide and plan the surgeries, whether it is a conservative surgery or the radical surgery, to differentiate whether there is adenomyosis or there is invasion, and also differentiate between the fibroids and adenomyosis, although it is overuse of that then. Hysteroscopy is direct visualization of the intracavitary regions, and it facilitates the biopsy directly. So general guidelines for the endometrial assessment is you can do the endometrial histopathology, which is recommended in any woman who is older than 40 years of age and who are less than 40 but at the higher risk of endometrial cancer, that is grade A level 2 recommendation. So all these risk factors are for endometrial cancer, like irregular bleeding, obesity, morbid obesity, endometrial thickness more than 12 millimeter, PCOS, diabetes, and a family history. Then you can do DNC for these patients, or hysteroscopy if the endometrium is thick on imaging, but histopathic examination is in desynchronization with the sonography finding. In all these patients, you are supposed to do hysteroscopy. Endometrial aspiration is also helpful, and this is a flow chart of how will you go for your management of these patients. Like suspected coagulopathies, go for the blood investigations. Then you do the lab analysis, or any presence of history of medication, then it will be labeled as iatrogenic. Then investigations, if they are normal, then just do if the women are more than 40 or high risk factors, then decide accordingly, and you can plan like if she's a malignant or just an ovulatory dysfunction, which we are going to come later to understand the basic principle of DUB. So this is the pattern of bleeding. One should understand, asking patients directly how many pads she is soaking. Otherwise, what Dr. Dipti said, the one patient complaining of menorrhagia may not be the menorrhagia for other patient. So basic mechanisms how the hemostasis takes place in menses are: one is the platelet plug and clot formation. Second is the prostaglandin meditation. This is very important. One should understand the basic role and the basic causative factors are the prostaglandins in all these DUBs and AUBs. The arachidonic acid and PG synthetase enzyme, they produces PGs, that is PGE2, which is vasodilator, PGF2 alpha vasoconstrictor, and thromboxane A2, which is also vasoconstrictor. Now, estrogen produces PGE2 and PGF2 alpha in 1:1, that is in equal preparation. Whereas progesterone produces PGE2 and PGF2A, thromboxane A2 in 1:2 ratio. That's the reason in premenstrual phase, there's a balance is shifted towards the vasoconstriction. So take it from me. This is the basic principle one should understand whenever you are treating a case of DUB, which molecule you are going to give. You are going to give estrogen, you are going to give progesterone. Third is the arrest of menstrual bleeding by tissue repair. This is because of the estrogen effect. The open endometrial glands in the denuded areas, they outgrow and they cover the raw surface. And thereby, whenever the endometrium is thin and patient is bleeding, there is no point giving progesterone. You are supposed to give estrogen, form an endometrium layer that will cover the bleeding points and that will take care of the DUB. So the classification of DUB can be just divided into anovulatory, that is metropathia hemorrhagica, and ovulatory, that is idiopathic or luteal phase defect. Now, in anovulatory DUBs, the adolescent girls and perimenopausal age groups are there. The dominant follicles, they don't develop LH surge to the sufficient levels. That's the reason there is no ovulation and no development of corpus luteum. So no progesterone. So no secretory changes in endometrium, and estrogen keeps on getting secreted. So there is an unopposed estrogen stimulation and hyperplasia. Now, this is the basic mechanism of the anovulatory DUBs. So one should understand this. And then the lack of progesterone causes decrease in PGE2 and avascular necrosis sets in, because to a certain level, the endometrium goes on growing in a proliferative phase, but then to a certain level, and the latest endometrium, which is outgrown, may not be supplemented with the enough blood supply, and it starts getting necrosed and starts getting shed off. So it is shaded in a everyday manner till the time everything is getting shaded off. That's the reason there will be a prolonged bleeding, and it will be a painless bleeding, as there is absence of PGF2 alpha and thromboxane also, which causes dysmenorrhea. Now, this is very important. Whenever patient says a painless prolonged bleeding, she is a case of anovulatory DUB. So the same thing I'm explaining here. Prolonged unopposed action of estrogen causes proliferative endometrium. If there is simple hyperplasia, can be treated with progesterone. If it's a complex, you need to go ahead, because there is chances of adenocarcinoma, go ahead and do the hysterectomy. Then there are histopathological patterns also, because of there is a cystic hyperplasia, and it is called as a Swiss cheese appearance, which everybody knows. The incidence of malignancy increases with the complex hyperplasia with atypica. That's the reason, and these are the high-risk women, like obese, diabetic, on estrogen therapy, hypertensive, infertile, and history of C endometrium in the family. So this is a atypical hyperplasia, atypical cells, and you are supposed to go ahead directly with the hysterectomy for these patients. Now, there is something called as threshold bleeding, which is often seen in perimenopausal women because of the insufficient development of ovarian follicles, resulting in low estrogen level, and that may not be able to sustain the endometrium to trigger the LS surge. So there is no ovulation. At the same time, there is no progesterone, so there is lack of PGF2 alpha also. And bleeding in these women can be controlled with cyclical estrogen progesterone, because both is absent. Estrogens are also absent, the progesterone are also absent. So the combination therapy is important in this patients. Now comes to the ovulatory DUB, which is very common in the reproductive age group, that is 21 to 40. Almost 20% cases of DUB are this. Now the patients will present cyclical excessive bleeding or premenstrual spotting, and the periods are associated with pain. As I told you, it is because of the thromboxane A2 secreted by the progesterone. And alteration in the ratio of PGA2 and F2 alpha, that is vasodilator and vasoconstrictor ratio, is altered in these patients in spite of the ovulation and normal progesterone secretion. So the PGF2 causes dysmenorrhea, and the endometrium reveals the secretory changes. So this is the algorithm, ovulatory and anovulatory. Everybody knows about this, and I have just now mentioned. So we'll go ahead. Now coming to the luteal phase defect, it's an insufficient and erratic production of progesterone, as well as alteration of the ratio, resulting in irregular and patchy secretory changes in the endometrium. So some areas are patchy, so there is irregular ripening or an irregular shading of the endometrium. So history taking is very important. Examination, as we said, we'll go ahead. This is the endometrial curate and the endometrial biopsy. Coming to the treatment part, where my lecture was supposed to start, but it's already been covered nicely. Let's go to the general principle. The first thing is the treatment of anemia, like comorbidity and other things. Lifestyle modification, as Dr. Dipti said, because PCOS, and that causes the insulin resistance and the morbid obesity with adipose tissue deposition, and those adipose tissue will again secrete excess of estrogen, causing the imbalance in the hypothalamo-pituitary axis, and thereby increasing the chances of endometrial hyperplasia, atypical hyperplasia, and adenocarcinoma. So the cycle goes on like this. And when it comes to the definitive treatment, that is medical or surgical. So the medical, non-hormonal or hormonal. Non-hormonal, like antifibrinolytics, PG synthesis inhibitors, capillary fragility inhibitors. This is the supportive treatment, which we always do as soon as the patient comes to us, before finding out if they are not willing to do the sonography, and it is an emergency. And the hormone, depending on the causative factor, we can give progesterone orally or intramuscularly, progesterone bearing IUCDs, estrogen progesterone combination, or estrogen only tablets for the thin endometrium patients. And other therapies are like danazol, GnRH, analogs, or milnacipran, testosterone. And surgical, like plain DNC, endometrial ablation, hysterectomy. So this is the algorithm. Low risk for endometrial cancer, medical management. You should, if the bleeding stops, observe. If the bleeding continues, TVS. If the endometrium is more than 5 millimeter, then do the hysteroscopy. If it's not available, saline infusion, salpingography, and if there is a focal lesion, treat accordingly, or you can do the endometrial biopsy. If there is echo is less than 5 milliliter, again treat, considering that it's a DOB and inactive endometrium. If the central echo is thickened, then you can treat accordingly, like of DOB, or the organic cause can be removed, as we discussed just little time back. With the abnormal bleeding, we can go ahead with the medical treatment, that is 3 to 6 months of medical treatment, or levonorgestrel intrauterine system. Or if there is no response, do the sonography. If there is a polyp, hysteroscopic polypectomy, or endometrial ablation if there is no response, and still there is no response, we can go ahead and do the hysterectomy. So if there is absence of risk factors, low dose OC pills always works. If there is a risk factor, do the DNC, send for the histopath examination, rule out atypical hyperplasia. If it's a simple, low dose OC pills and cyclical progesterones, or hysterectomy, as we have already discussed about this. So which are the non-hormonal drugs like antifibrinolytic, tranexamic acid, PG synthetic inhibitors, mefanic acid, which is very important. I told you why mefanic acids are so effective, because they do the PG synthesis inhibitions. And the capillary fragility inhibitors, ethamsalate. Nowadays, there is a diosmin molecule also, venusmin, which causes the capillary stability and reduces the bleeding. Coming to the hormones, progesterones like norethistron, eroxyprogesterones, or dadogestrones, they arrest the bleeding and can be given cyclical also. Initial loading dose can be 10 milligrams 6 hourly for 2 days, and then followed by 10 milligrams per day for 15 to 25 days, and cyclically from 10 to 25 days to cover the later part of the cycle. You can give in combination also, you can give only also, and danazol and GnRH analogs also can be given, that is the injection 3.6 milligram intramuscular once in a month. And ormeloxifene, everybody knows about the molecule Sevista, which can be given very easily bi-weekly, cheap, and no much of side effects, and very nicely effects. So whenever patient is perimenopausal or little higher age category, or not interested in hysterectomy, and there is no high risk factor, then you can go ahead with this. How the progesterones act? They arrest bleeding within 2 to 3 days by doing a medical check curettage. What do you mean by medical check curettage? They convert the hyperplastic proliferative endometrium into the secretory phase, and thereby stops the bleeding. Then LNG, this is a levonorgestrel bearing IUCDs. They reduce the blood loss up to 90%. In fact, most of the times after 6 months, there is amenorrhea in most of the patients. It gives the protection against the endometrial CA also. It's very effective as a contraceptive, just by releasing 20 micrograms of levonorgestrel daily to the endometrium. There is no side effect because it releases the locally by causing the glandular atrophy and stromal desodalizations. So it's wonderful, though the cost is high, but now the 2-3 companies are come in the market and the cost is reduced because of the competition. Coming to the surgical treatment of DOB, one can be conservative, just do a DNC. It is diagnostic also and therapeutic also. By removing the hyperplastic endometrium, in you are sending for the histopath examination at the same time. You can do the endometrial ablation also, or there can be radical surgical treatment like hysterectomy, pan-hysterectomy. Ablations means elimination, which is indicated for the failed medical therapy or the young woman who desire to preserve the uterus, or poor surgical risk for hysterectomy. Of course, they are non-carcinoma lesions. And the contraindications obviously are desire for fertility, or the large uterine cavity, or hyperplasia with atypia or suspected malignancy. There can be first generation technique like laser, transcervical resection, or second generation like thermal balloon, microwave, or cryoablation, or laser interstitial therapy. These are the various photographs how we can go ahead. And the disadvantages are they require skilled person, long training, general anesthesia, more chances of perforation. But the results are 30% remain amenorrheic, 40 to 50% they are reduced bleeding, and the 10 to 20% they require hysterectomy with the failure of the technique. So hysterectomy indications, as I said, the hyperplastic endometria with atypia is the first indication. Whenever you see atypia, go ahead and do the hysterectomy. Failed medical therapy, high risk category, or a suspicious patch, you can go ahead. So the summary of the DUB management as per the age group: in the adolescent, do the sonography abdominally, obviously. Endometrial sampling is seldomly done, or if she's not married, and medical management is that is sufficient. Surgery is seldomly done. In the reproductive age category, sonography is frequently done, and you can do the TVS also. And the endometrium sampling is required. The medical management is the first line of therapy, but you can do the surgery also depending on the situation. But the perimenopausal age group, you can do abdominal transvaginal sonography. Endometrial sampling has to be done to rule out the atypia or malignancy. The medical management, yes, we start with the first line of therapy, but then most of the time surgery is the better option. So the key points for this are: AUB can be due to organic disease or functional disorder. Depending on that, it can be AUB or DUB. It can run in any age group. DUB is diagnosed by exclusion of organic lesions. The hormone should be given as first line of therapy. Only if the medical management fails, then you can consider surgical options. And if there are any contraindications or there is atypica, you can go straight ahead with the hysterectomy. Thereby, DUB, the treatment is to be done individualized approach. Thank you for listening very patiently. I hope I haven't taken much of time. Thanks a lot.
Thank you, sir. Over to the chairpersons, please. Yes, Dr. Aparna.
Aparna, your voice is not audible. Aparna, your video is also gone.
Madam is only gone. So, anybody else wants to say something? Yes.
I will tell.
Anini,
Khedkar sir has- Yes.
Hello, Lalita, I'm commenting. Can you hear me?
Yeah, Aparna, we can hear you.
Yeah, I was just telling you have not taken much time, but rather bombarded us with each and everything, in such a short time. So it was like I had to stick to my mobile to really follow you up. And as you rightly said, AUB is a diagnosis of exclusion. We have to rule out or exclude each and everything possible which can all the causes to label her as AUB. And the OPD, almost 50% of patients, you said that they are coming with the complaints. We have all the patients like जिसकी bleeding हो रही है उसको बंद करना है, जिसको नहीं हो रही है उसको चालू करना है, and then you have to titre each and every drug to do so. One thing I wanted to mention, ormeloxifene is a very nice drug. It is rather cost effective, cheap, especially for those patients who are not affordable and in puberty menorrhagia cases, but you have to monitor the patient for ovarian cyst if you are
Cyst
giving
formation.
her for
There is
more than
definite
3 months.
incidence of
Because many a times the cyst, they are simple cyst, but the general practitioners or those patients who are like doctors who don't know that this is caused by ormeloxifene, they may tell the patient that you have developed cyst and patient gets unnecessarily bothered. So thank you very much for explaining us all the everything in detail. It was a very nice lecture.
Thank you, ma'am.
Lalita ma'am, you wanted to say something? Lalita Bajaj ma'am?
Yeah, she wanted to tell something. Yeah.
Yes, ma'am.
Yes, sir has explained everything very nicely. Any time to listen to Dr. Vinayak Khedkar sir, it's really pleasure. He's very cooperative also, extra social for us. But in this topic, the sir has explained everything very nicely, how the management is to be done, how ovulatory and ovulatory cycle and where to start. It was completely covered very nicely. Thank you, sir.
Thank you
very much.
Thank you, Lalita.
Sir
Thank
is
you so
always
much, Vinayak sir. I actually like to work everything towards the basic physiology. And you really started everything from physiology. So I think for the first time, I'm hearing somebody who has a thought process like mine. So I'm really very happy. Thank you, sir.
Thank you, ma'am. Thank you. So nice of you.
Thank you so much, sir, for
Vinayak
joining
sir
us today and accepting our invitation, ma'am.
Ever smiling face, sir. Vinayak sir.
Thank you, Rekha ma'am.
Thank you, sir.
So, sir, if you all can stay back and enjoy the panel, it would be great.
Yes, ma'am. Will definitely.
But Patel, sir, are you there?
Yes.
May I start the panel, sir?
Oh, yes.
So we start with the panel, which is legal issues in high-risk pregnancy and labor. Dr. M.C.Patel, sir, is the expert in the line of fire, and I will be coordinating the panel. Sir has not been properly introduced, so I take the great honor of introducing sir. He is a consultant, obstetric gynec specialist, and medical legal counselor. He was VP Foxy 2018, organizing secretary AICOG 2017, chairperson Ethics and Medical Legal Committee Foxy 2011 to 13. He never stopped being a medical legal advisor since then and has been giving his knowledge and services free to all Foxians all the time for the last 11 to 15 years. So he has organized many conferences, but more than all this, he is extremely consistent, very down to earth, and very people-minded, because he's been going to the Northeast for the past 21 years, serving the underprivileged women over there. And as he likes to say in his lectures, keep my visiting card under your pillow and sleep well. He actually does it. So, sir, I'm honored to have you here as our specialist. I've been introduced. And here is a short video from sir.
शुभं करोतु कल्याणं आरोग्यं सुखसम्पदम्.
Respected seniors and dear colleagues, serving Foxy for years together, on this auspicious day, with folded hands and down head, I seek your guidance, blessings, and support to endorse my candidature for the post of Foxy President, year 2026, election year 2024. Consistently working for Foxy and trying to visit even a smaller societies and to assist our common Foxian friends in any given situation, I have tried to serve Foxy. I assure to serve Foxy in the same way with the same zeal and enthusiasm. पथ का अंतिम लक्ष्य नहीं, सिंहासन चढ़ते जाना, लिए सभी को साथ, आगे है बढ़ते जाना.
So, the voting for President Foxy is 1st August to 10th August, 10 a.m. in the morning to 5 p.m. 10th August. Please vote. Now, we will introduce our panelists as they come along in the program. I request for your vote for me as well. My voting would be 16th to 25th August 2024. Now, before we really go seriously into the topic, as always, I like to ask this question to sir, that is this topic worth discussing? Doesn't everybody know about it?
Yes, absolutely yes. Because if we go with the statistic of medical legal cases in USA, 78% of gynecologists are sued at least once in their lifetime, and 37% gynecologists are sued more than 3 times, and nearly half of the malpractice cases relates to obstetric problem. And if we go with statistic of India, then total number of cases, gynecologists rank first and shares 29% of the total cases as far as medical legal consequences are concerned. And that is why we have to be careful, we have to be vigilant, and we have to discuss this type of topics not to end up into litigation, and if at all ended, then how to get rid of it is our motto. And as far as this medical legal issues in our obstetric practice is concerned, labor or high risk pregnancies or etc. So whenever something goes wrong, it's a potential situation to face litigation, and that is why we have to know, or it is worth discussing as far as medical legal issues in labor and high risk pregnancy is concerned.
Thank you so much, sir, for that laying that foundation. Now, I would like to introduce Lalita Swami, ma'am, who's the president of Osmanabad Society and president of DWIMA Osmanabad. She's a consultant at Swami Hospital for the last 15 years, director Swami Hospital. Welcome, ma'am.
Thank you, ma'am. Thank you. Hello.
Yes, ma'am.
We
can hear
you.
Evening.
Good evening, madam. Thank you. My question is, hello.
Yes, welcome.
Yes, ma'am. Please
you
go ahead.
are audible, madam.
Yes, sir. Yes, sir. My question is, sir, why litigations are common related to the pregnancy and labor? Any case related to this? Which are the areas?
Please ask one by one.
Okay, okay, ma'am.
So, sorry. Your first question, why litigations are common related to pregnancy and labor? Because usually we deal with young patients, usually. And usually they are book patient. Of course, in few of the conditions, they are brought in an emergency also. But usually they are book patient. They comes on foot. Usually patient comes walking in hospital. Of course, there are few conditions when patient is brought in ambulance or so. So young patient comes on foot, book patient. So they have high expectation from us. And they consider this normal labor process or delivery, etc., very physiological rather than pathological. And naturally, we are dealing with two lives, mother and fetus. So, expectation on part of patient and relative are much higher, and these are the potential situation as far as consultation, litigations are concerned.
Yes. Any case related? Hello, sir. Any case related to?
There are so many cases related to this during pregnancy or during labor if something goes wrong and litigations happen. Say, for example, it was case antenatal patient. Regularly, patient was conceived with IVF treatment, and every time sonography was done, and every time she was told mild polyhydramnios and everything is fine. At 34 weeks of pregnancy, during routine checkup, it was found that it was case of intrauterine fetal death. So patient was advised to go for cesarean section, and all investigations were done. And as far as this investigation is concerned, in that very investigation, blood sugar was also advised, which came out to be 432. And before that, never blood sugar examination was advised. So in this type of situation, when you fail to advise some important investigation as far as high-risk pregnancy cases are concerned, and you are liable for litigation. In this case is filed. Of course, case is yet to decide, but case was filed in this situation. So there are so many cases. We will discuss one by one in further discussion. Yes, next.
Okay, sir. My next question. Which are the areas for litigation?
So as far as our labor part and high-risk pregnancy cases are concerned, common allegations are delayed in diagnosis, investigation or treatment, wrong diagnosis, no consent, staff not qualified, infrastructure issues, unnecessary investigation, emergency services not rendered properly, communication failure, delayed in transfer. if at all we have to transfer patient to higher center, and if it is delayed, then it is also one of the common allegation in this type of situation. And congenital anomalies, if we miss congenital anomalies, then it is also one area as far as litigation is concerned. Complications and morbidity, fetal or maternal or both, mortality in few of the cases, maternal and or fetus, overcharging. This allegation has come up in this era, that tremendous charges against unexpected result. And one more allegation is ask for record, and if we have not provided record, then also it becomes a case for litigation.
Sir, which are the assisted obstetric situations which may lead to the litigations?
So before that, I will continue to that area of litigation also. Many times, improper diagnosis of fetal distress leading to this problem or delayed in delivery is also one of the cases. Improper monitoring during labor, improper interpretation of CTG, improper application of instrument like ventouse or forceps. And as far as cesarean part is concerned, we are blamed both way. If we go with cesarean section, unnecessary cesarean section was done for no reason. And if we do not go for cesarean section, then there will be one more allegation. Cesarean section was not considered or not done in time, could be one more allegation as far as litigation is concerned. And as far some obstetric situation are concerned, when we go with external cephalic version, of course, nowadays very few practitioners would be practicing, otherwise straightway one go for cesarean section. So external cephalic version, internal pudelic version, vacuum delivery, forceps delivery, failure of procedure, and operation, birth injury, hemorrhage, infection, complication of anesthesia, and cesarean section related issues. And as far as birth injury concerned, say for example, obstetric anal sphincter injury, perineal lacerations, or paraurethral or urethral lacerations or tear, cervical injury, rupture of uterus, VVF, RVF. So there are so many conditions we may end up into problem. As far as fetal part is concerned, if at all it is hydrocephalus and we have to consider craniotomy, so it may also invite litigation if we have not explained properly. Birth injury, asphyxia, infection, fracture many times, fracture of skull, fracture of clavicle, fracture of long bone of fetus. These are some areas as far as litigations are concerned. Yes.
Thank you, sir.
Thank you, sir. Now we have Dr. Shreya with us. She is a consultant and director at Chandak Hospital, Parbhani. She is an FMF certified obstetrician-sonologist, associate life member of AMASI. Welcome, Dr. Shreya.
Thank you, ma'am. So my question for you is, there's a case, baby Ramya versus Dr. Aruna Reddy. It was a case in 1995. Facts of the case were it was a forceps delivery and a 4.5 kg baby was delivered vaginally. The baby developed brachial palsy. Case was filed, and defense on the part of doctor was, it was a complicated case. Patient refused for consent for cesarean section. Baby was getting asphyxiated. Inference held by court was, the patient was admitted at 6 a.m. and the delivery started at 4 p.m. No investigation or sonography was done. No evidence that consent was refused. Court allowed rupees 1.75 lakhs. Where things went wrong?
So it was a case, in that very case, baby was 4.5 kg. So it was big baby. So when we try to deliver this big baby vaginally, proper counseling and consent is very much must. And in this situation, when patient refuse to give consent for cesarean section and they insist to go for a vaginal birth only by instrument or so. So at that point of time, proper counseling and consent with all risk involved should be done and it should be documented. If patient has refused for cesarean section, then negative consent is also very much important. And in this, if we have taken negative consent, then it becomes good defense in our favor. So in this case, it was not mentioned. And one more allegation that patient was admitted at 6 a.m. and delivery started at 4 p.m. and no investigation in between. But it is a matter of argument that if there is no problem, if everything is going smooth, and on clinical examination, if everything is fine, it is not necessary that one should advise some investigation. Of course, we can go with CTG or we can go with normal fetal heart monitoring, etc., with this partogram, etc. So if we have done like this, then no special investigation required. Of course, if there is any problem and we have to go for any investigation, it's a different story. Otherwise, this type of allegation can be challenged in court of law. Yes, next.
Thank you, sir.
Yes, Dr. Asha.
We have Dr. Rupali. She's an assistant professor, Government Medical College, Sambhajinagar. That is good. Aurangabad. She's worked as co-PI project on ESM UBT in collaboration with MGMIS Varda and Harvard University. So welcome, Dr. Rupali, ma'am. Dr. Shreya, would you take this as well? Because I could not contact her actually.
Okay, ma'am. Neena Gupta versus Deep Nursing Home, 1996. Facts of the case. It was a forceps delivery. Utrovesical fistula was identified. Defense on part of the doctor was it occurred during the process. Inference held by the court was liable where things went wrong.
So in this case again, when it was case of forceps delivery, a proper counseling is very much must. And it is not necessary that utrovesical fistula could be due to trauma by forceps, because usually it should not happen. But if it is a prolonged labor and if aid is stuck up and there is a pressure necrosis in that very area, and after 3-4 days, if that necrotic part is sloughed out and fistula develops. So in this situation, proper counseling is very much must whenever we are going to go for any instrumental delivery or operative delivery. So here it was lacking as far as this part is concerned. And when this fistula occurred, then one more question: did you diagnose that complication well in time? Because whenever you are facing this type of litigation, first questions come: was it preventable? And usually cannot say no. But in spite of all your care and caution, if it happened, then did you diagnose that complication well in time? And did you manage that complication way in which any prudent gynecologist would have managed? So if you have diagnosed this utrovesical fistula, and if you have advised them properly, if you have managed that fistula either at your place by yourself or involving our other colleague, or you may have refer patient well in time to proper place with proper person, then in this type of cases, it becomes favorable in our favor as far as litigations are concerned. In many of the cases, court has considered ultimate result is not taken into consideration. but your efforts to save life of patient, your efforts to prevent complication, your efforts to deal with complication are taken into consideration. Next.
Thank you, sir.
Thank you, sir. Now we have Dr. Ashwini Kubade, ma'am. He is a consultant gynecologist and assistant professor at GMCH Parbhani. She also works at Aditi Fertility Clinic Parbhani. Over to you, Ashwini, ma'am.
Thank you, ma'am. Thank you very much, sir and ma'am, for this opportunity. Sir, please discuss the birth injury and litigations, and which injuries are more likely to cause litigations, and what is this type of negligence and other types of negligence.
So, as far as birth injuries are concerned, either it could be maternal injury or fetal injury, and both are area for litigation. As far as maternal part is concerned, obstetric anal sphincter injury, and leading to which may cause a complete perineal tear also, leading to incontinence of stool is one area for litigation. Vulval hematoma, perineal tear, perineal hematoma, lacerations, paraurethral injuries, then cervical injury, uterus rupture, VVF, RVF. There are so many areas as far as birth injuries are concerned. And as far as uterine rupture is concerned, whether it is repairable or uterus is to be removed, then if uterus is to be removed and patient is still keen to have further pregnancy, it becomes an area for litigation. As far as fetal part is concerned, related to birth injury, fetal asphyxia and leading to birth asphyxia, iphel hematoma, fracture, scalp or long bone, clavicle, etc., earth palsy and cerebral palsy in future also may invite litigation. Injury during breech delivery, it is very common allegation nowadays. And during cesarean section, sharp cut by knife over body of fetus is also one area. And sudden perinatal death is also one area as far as this part is concerned. And it is very obvious when fetal injury especially goes with permanent ailment or residual effect, these are the more vulnerable area as far as litigation is concerned. Yes, next. What is negligence was one more question. So in our study in forensic medicine, we were taught two words, act of omission and act of commission. Act of omission means to omit something which prudent doctor will not omit. Say, for example, if patient comes to you to take full dose of injection penicillin. So no prudent doctor will go straightway with full dose of penicillin. He will go with test dose, and if it is negative, then only he will go with full dose. So this is act of omission and act of commission. So doing something which prudent doctor would not do. So in this situation, say for example, if you have planned surgery and under general anesthesia, and if patient has come up with full stomach, so to give anesthesia on full stomach in elective surgery is act of commission, because no prudent doctor would go with this, because if it is not emergency, if it is plan one, and if patient has come up with full stomach, then we can postpone. But if one goes with general anesthesia and if something goes wrong, then it may invite litigation. As far as type of negligence is concerned, there are major two types, civil negligence and criminal negligence. Just next.
So, next we have Dr. Sunita Khedkar, sir. She is the Cultural Secretary of Aurangabad Obstetric Gynec Society, a very, very talented dancer, sir. See, very talented dancer, practices yoga and has many, many extracurricular interests. So welcome, Sunita ma'am, and over to you.
Thank you, ma'am, for the kind introduction. Good evening, sir.
Good evening. Welcome.
Sir, what is the importance of consent and is consent necessary in case of normal labor?
So, as far as importance of consent is concerned, in one famous case, C. Jaipal Reddy versus Padmini Veluri, it was decided in National Commission, and in that very case, National Commission has very good comment that consent is not mere piece of paper where patient or patient party has to sign, but it is a very important document of your counseling, of your consent. So whatever you counsel, whatever you communicate to the patient, each and every point should be mentioned in that very paper, and then patient and patient party has to sign. So consent is not mere piece of paper. And in very famous, one more famous case, Samira Kohli versus Prabha Manchanda, it was decided in 2008. And in that very case, Supreme Court came up with guideline that what is the ideal consent in Indian consent. And the court came up with guideline how we should take consent. So consent are a very important part, and we have to go with proper consent only. Yes, the next question was, is it necessary in case of normal labor? So as far as normal labor part is concerned, it is not usual practice in India to go for consent in normal labor, but it is always advisable because we never know how this normal process of labor will end. It may end up into complete perineal tear, and we have to go for repair under anesthesia. And at that time, if we take consent, then argument could be on part of prosecution that patient was in agony of pain, patient was in agony of labor, and patient has given consent. So patient was not with sound mind, and when consent is not given with sound mind, consent cannot be considered valid. So in this type of situation, not to end up into problem. Say for example, during process of labor, if we have to consider vacuum or forceps delivery, then also we have to go for consent. And even we go with consent at that point of time, then also the same argument will be there on part of prosecution. So it is always advisable to go for consent for normal vaginal birth at the time of admission only. If it is possible, if you can give all the consent paper to patient during visit, they can take all this paper at home, they can go through, and on next visit they can sign the document, or on admission they can come and sign the document. Is also one way as far as consent is concerned in normal labor. But many a time patients are brought in an emergency, so you can take consent on admission also. There is no issue. But consent for normal vaginal birth is also very much required. And on Foxy website, it is available. With three medical legal experts, Dr. Nikhil Datar from Mumbai, Dr. Dilip Walke from Pune, and myself, Dr. M.C.Patel from Ahmedabad, we have prepared 30 different consent. And in those consent for normal vaginal birth is also there. And in that very consent, we have mentioned that during process of labor, trying vaginally, she may require instrumental intervention, either to go with forceps delivery or with vacuum delivery. That also we have mentioned. And we have also mentioned as far as birth injuries are concerned, including third degree perineal tear or complete perineal tear. And in that very we have mentioned, of course it is rare, but it may happen. So we have not frightened the patient, and still we have mentioned. So that way we have prepared a consent for normal labor also. So it is always advisable to go for consent for normal vaginal birth also. Yes. What was the last question?
What is the importance of record and what is the importance of discharge card?
Naturally, records are always at your rescue, because whenever you are facing any litigation, record tells how you have managed that very patient. So record is always at your rescue. So records should be kept up to date. What was done, nothing was neglected, and given treatment made fully as demanded by law and ethics. It should be as per standard medical norms, and we can prove by record only that we had treated patient as per standard medical norms. As far as discharge card is concerned, record is of course very important, and discharge card is also part of your record. So at the time of discharge, naturally we will give all the details in discharge card, normal details of the patient, provisional diagnosis, treatment, investigation if we have advice, then it is also to be mentioned, and instruction at the time of discharge. Say for example, diet to be taken, medicine to be taken, exercise, follow-up, and very important part is reference. If at all we have advised patient to have second opinion with our professional colleague or any other specialty, we have to mention at the time of discharge in discharge card. And why this is very much important? Because in one of the cases which happened in state of Tamil Nadu, it was preterm delivery, premature delivery rather. Baby was admitted in NICU, due course baby was discharged. But during admission in NICU or at the time of discharge, parents were not advised to go for opinion from ophthalmologist to rule out retinopathy due to prematurity. And ultimately baby went blind, case was filed, and case was decided in favor of patient. Compensation of 1.8 crore was awarded in favor of patient. And out of those, 1.73 crore was by government of Tamil Nadu because it happened in government hospital. And rest of the amount was to be paid by neonatologists. In this case, gynecologists were not made part. Yes, next.
Thank you, sir. Now we have Dr. Anil Kayande, sir, who is the past president of Jalna Obstetric Gynec Society.
Yes.
He's been the president for 5-6 years. His areas of interest are high-risk obstetrics. Welcome, sir.
Yes, welcome, Anil.
Sir, good evening.
Good evening. Good evening.
Yes, I
Sir,
am Dr.
Vijay sir. Good evening, sir.
Good evening. Yes, Anil sir, continue. Hello.
Sir,
yes.
I have a question. Patient.
Yes.
Anil sir, you are not
सर
audible.
आपकी आवाज चली गई.
Hello. Anil
Yes,
sir, are you
Anil.
there?
Yes. Welcome.
Or take patient to any other hospital. After 1 hour, attendant give consent for cesarean section, but asking for guarantee of mother and baby. What to do? LACS perform. Sir. Hello.
So very important part. When you feel that now cesarean section is required, considering some indication, and if you have explained well, and even in that situation, if they are not ready to give consent, because usual argument could be her husband is not available, he is coming, we have called him, let him come, and then we will decide to give consent. So at that point of time, whatever situation is there, as far as the baby part is concerned and mother part is, it is to be mentioned in case paper, it is to be explained to the patient, and signature of patient and one witness should be taken that it was explained that cesarean section is very much required. After 1 hour or 2 hours or so, when they becomes ready to give consent, so till then, when we advise,
I have question part 2, sir. LACS perform asphyxiated baby with low Apgar delivered. Baby got convulsion after some time, so intubated and shifted to NICU. Attendants now blaming doctor saying false hope for normal delivery giving. Wrong medicines are given. Fetal heart not checked in labor room. One injection administered which stopped the progress of labor. And situation is created such that compliant is compelled to give consent for cesarean section.
So I was discussing when they become ready to give consent. Naturally, say for example, after 2-3 hours, they are ready to give consent. So situation is naturally changed. So we have to explain again that now this is the position as far as mother part is concerned, as far as baby part is concerned, and we have to explain everything. Many times, just in this case, they ask for guarantee. You cannot give guarantee because you can give guarantee of your best efforts. But as far as result part is concerned, you cannot give guarantee because in eye of law, when you claim to be master, you are supposed to be master. And if you have given guarantee and if you couldn't give that result, then it will be very troublesome as far as litigation part is concerned. So you cannot give guarantee. And when in this type of situation, when they have given consent after 2 to 3 hours, and we have proceeded with cesarean section, naturally in this type of situation, in few of the condition, SP-excited baby may deliver, and we have to shift that very baby in NICU care. But before go for cesarean section, we have to explain patient and relative that now it is all likely that baby may come SP-excited, and we have to consider NICU backup also, NICU treatment also. If we explain everything, then it becomes easier for us to deal with in court in this type of situation. And one more allegation that some injection was given, so it stopped pain. This type of allegation doesn't stand in court of law because whichever record we have submitted to the patient and those records are submitted in court, in that very record, whatever injection we have given, we have mentioned, and they will have to prove which injection they mean that this is the injection that doctor gave that very injection which stop the pain. So burden of proof is on part of prosecution to prove whichever allegation they put. So nothing to worry in this type of situation.
Okay,
yes,
sir. Thank you. Thank you very much, sir.
Yes.
Dr. Shinde sir is already here.
Yes,
he is
Vijay.
an LLB, MBBS, DJO, FCPS, DFP, obstetrician, gynecologist, endoscopic surgeon, sonologist, infertility consultant. How many caps do you have, sir? Yes. And he is the director of Eye Hospital Private Limited, Jalna. Welcome, sir.
Yes, Vijay Babu.
Yeah.
Welcome.
Good evening, sir. Good evening.
Good evening. Good evening.
Sir, just I have one question, like related to the previous case.
Yes.
Like we have given a fair trial to the patient, and the patient has now delivered within difficulty, and but now the baby is having cerebral palsy. Now the attendants have filed a case against the doctor saying that it's a mere mistake of a doctor that they couldn't handle the labor properly. So how to deal with this situation and how to answer the relatives?
So in this situation, when we advised to go for cesarean section first time, they had refused. Right. So in this situation, when patient doesn't follow your instruction, it becomes contributory negligence on part of patient, and it becomes good defense in your favor. So if you have mentioned everything in record that the cesarean section was advised at that point of time, they didn't give consent, and they give consent after 2 to 3 hours or whichever, then it becomes easier for us to face this type of situation. As far as cerebral palsy is concerned, so now in few of the cases, court has also come up with discussion whether there was any antenatal reason to lead to cerebral palsy. One, second part, intrapartum. So during process of labor, is anything went wrong which may lead to cerebral palsy? And after delivery, if something went wrong and it led to cerebral palsy. So now merely on ground that baby developed cerebral palsy, doctor cannot be held responsible. But that way case is decided. But in this situation, we have to argue ourselves with proper documentation and how we have managed that very case. If you have managed that very case as per standard protocols, as per standard guideline, as per standard medical norm mentioned in standard textbook, or practice prevailing in nearby medical college, or practice prevailing in peer groups. So if we can prove, then we are out of problem in this type of situation also. There are so many cases decided in favor of doctor, even if there was a case of cerebral palsy or so in future. So it is not necessary that once cerebral palsy happens, then every responsibility on doctor's shoulder.
Yes, I have another question, sir.
Yes.
There is a 42-year-old female, like who has come to the casualty with a complaint of abdominal distension, pain in abdomen, and just UPT was done and it was positive, and she was diagnosed on ultrasound to be having ruptured ectopic. Now that patient was supposed to taken for the surgery, and we tried to take a consent for that surgery, but it was found that she was a widow, and she wanted that this thing should not be revealed to her relatives. But when we inquired more, she said ki if at all you want to reveal the thing, you should reveal to the person with whom relationship she has got pregnant.
Yes.
So how to take a consent in this case?
So you mentioned that she is 42 years.
Right, sir.
When patient is major, when patient is mentally sound, she can give consent. And nobody else can give consent on her behalf. Whosoever other person signs, he or she is witness only.
Okay.
And as far as in eye of law, what is witness? Witness is simply means patient has signed this document before me. Witness has nothing to do with content whichever written in consent paper. If we go in true spirit of law, then there is nothing to do with this. If patient is major, patient is mentally sound, and patient is not ready to disclose that it is a case of ectopic pregnancy and she is widow, we cannot and we should not. If she is interested to declare that with that very person whom she had relation, you can declare, because she is major and she has taken decision that she had relation and it was result of consensual sex. There was no rape, no sexual assault or so. So if she is comfortable to invite that very person during discussion and to declare to him, fine, that is up to her. But everything, whichever she wants, we have to mention in consent paper, and it should be well documented, because these are the cases which may lead in the court, and as far as litigation part is concerned, we have to make our side very clear.
Sir, one more question, a short question. Yes. We have a patient comes in the labor and we have taken due precautions like properly monitoring of the intrapartum events. All things went fine, but the baby has not cried immediately after birth. Like for that matter, we have monitored the patient continuously and intrapartum monitoring, but the baby has not cried. And that later on the pediatrician attends the case and he says it's an birth asphyxia. The thing he puts like an birth asphyxia on paper. And relatives baby was shifted and the relatives said how it has happened. So that time anyhow we consider that we have monitored the patient properly, investigations were done in a proper way, but unfortunately the baby has not cried. The relatives were like non cooperative that time, but anyhow we managed. But after 15 days, they came and they said it is a pure negligence on your part, so that the baby has gone asphyxiated. We said, why it has happened? Like, who told you about this thing? Then they said, the pediatrician has clearly written on the paper, it's an birth asphyxia. So they went for a litigation. But after 2 months, when we went into the situation, it was found that the baby had metabolic disorder. And like it was not revealed to us, but we went on searching for the matter to the pediatrician. Then after 2 months, he revealed that it is a case of metabolic disorder, because of which the baby has not cried. But now in the court, the people are there with the same papers. Like pediatrician has written on paper birth asphyxia. So is it valid that every time the pediatrician writes for any small things, they keep on writing like birth asphyxia? Maybe early hypoxia or late hypoxia, but they do write on a paper immediately, because they just consider the baby has not cried immediately after birth, and the reason is birth asphyxia. So how much like we should deal like with such situations?
So in this type of situation, first thing, in that very hospital, is it routine to keep pediatrician or neonatologist present at the time of delivery, irrespective of mode of delivery, normal, instrumental, or cesarean section? If it is like that, naturally you hand it over baby to the neonatologist straight away without doing anything. If it is not routine and you are managing baby also, and if at all there is something wrong, you invite pediatrician or neonatologist. This is a different story. In this situation, if we came to know that it was something metabolic disorder, did you demand papers related to this metabolic disorder through court from patient party? You can demand. And if we can prove, then it is not birth asphyxia, it is not at all any carelessness on part of treating doctor, but it is related to metabolic disorder. But in this situation, one more questions come, that if at all it was case of metabolic disorder, can it be diagnosed prenatally? If yes, then one more allegation will be there. What did you do to diagnosis? And if it is not, it cannot be diagnosed antenatally, then you are out of problem. But in whatever situation we face, we have to go with this only, that we have taken utmost care of that very patient as per standard medical norms. So labor ward protocol we have to strictly follow. Say for example, the CTG etc. if we have facility, and if we are going with CTG etc. and if every tracing of CTG is normal, then naturally one may presume then everything is going fine. If at all there is abnormal tracing of CTG, then only he or she has to switch over to either instrumental delivery or cesarean section or so. So if we can prove that we have taken utmost care, then ultimate result is not taken into consideration in court always. Your efforts to prevent, and if at all it happened, then did you diagnose in time and did you manage way in which any prudent gynecologist would have managed? If you can answer in this way, then you are out of problem.
Yes. Thank you, sir. Thanks a lot. Sir. Thanks a lot.
Thank you, sir. We have next Dr. Anuradha Garag, who's the past president of Osmanabad Society, and she's not here. So requesting anybody from Osmanabad or anybody to please take this question. Anybody who's present here.
Yeah. Should I take, ma'am?
Yep. Please go ahead, sir.
Yeah. Sir is on call. A 32-year-old primary full-term was admitted for labor pain. No significant past medical history. ARM was done and the liquor was clear. Patient had sudden cardiac arrest while in labor and was pulseless and BP was not recordable. CPR was given immediately. In this case, amniotic fluid embolism was suspected. The patient was intubated and started positive pressure respiration immediately. The patient showed signs of partial revival. Why should be done? What should be done? Should LSAS be done immediately as a fetal heart was present, or patient should be shifted to ICU to the higher center?
Yes. So in this case of amniotic fluid embolism, there are few cases which are decided in favor of doctor. So it is not necessary if it is a case of amniotic fluid embolism and straightway case is lost. So if we have taken utmost care in this type of situation to diagnose the situation, to resuscitate, and all the efforts to resuscitate, and if patient is resuscitated, then to shift in ICU in nearby center, all this taken into consideration. As far as peripartum cesarean section is concerned, during resuscitation, it is a part of treatment, but it is a double-edged sword. If you go with this, of course, it will help in resuscitation, because as soon as baby delivers, then pressure on aorta, aorta and is relieved, and so it will help in resuscitation also. But it is not at all guaranteed that baby and mother will be saved. Of course, there is one incident which happened in our society of Riva, one of our gynecologist friend went with peripartum cesarean section. Baby was saved and mother was also saved. But in this situation, whenever we do whatever we do to save life of patient is always pardoned in court of law. We can prove in court of law. So if we consider peripartum cesarean section, then it is also considered because it is a part of resuscitation also. But if we can very quickly bring any close relative that this has happened and this is the only way, but it is not guaranteed. If we do not do anything, then she is almost going to die. But let us try. That way, during your cesarean section, you can explain to the relative not to end up into further problem.
Next, we have Dr. Rupali Gaikwad, ma'am.
Yes, ma'am. Good evening.
Welcome, ma'am.
Thank you, ma'am.
She's practicing for 14 years at Mediarts Hospital. She's the honorary secretary of Aurangabad Society, and she's also done her LLB. Do I remember that rightly, ma'am?
Yes, ma'am. Yes, ma'am. I've finished my LLB.
She is also an LLB, sir.
Yes.
So,
very good.
Thank you, sir.
Over to you, ma'am.
Yeah. Thank you so much, Asha Jain, ma'am, and Dr. M.C.Patel, sir, for the opportunity. On behalf of Aurangabad OBGYN Society, we wish you both best of luck for the elections, sir.
Thank you.
We all are with you.
Thank
Sir,
you.
Thank you, ma'am. Sir, I just want to ask about the most fearful situation in this case. What if the patient immediately expires? How to handle the patient? Even if the patient is shifted in an ambulance to another hospital, the doctor is accompanying the patient, but still the patient expires due to some reason. And if the patient is brought back to your same hospital and the relatives are creating a nuisance, how do we handle the situation, sir? And whom should we call for help?
Naturally, in this type of situation, we have to call police also and we have to call our professional colleague also. Because if police is there, then they will tackle the situation accordingly. Now, before that, if patient immediately expired during our, say for example, if it is a sudden obstetric collapse, naturally we have to go for resuscitation. We have to ask for help also. So if you have a phone call to your professional colleague, they will be at your rescue and it shows your effort to save life of patient. If there is a good resuscitation, immediately you can ship patient to nearby ICU center also. But in spite of all your efforts, if patient expires, and if you have already called your professional colleague, now quick discussion with your colleague, and before you declare, because once you declare, there could be problem, we know. So in this situation, if you have apprehension that relative may go hostile, then you can inform police in advance also this has happened, and you can advise post-mortem examination also. So these are the very tricky situation rightly mentioned by you, and we have to tackle accordingly. But it is always advisable. Once patient is expired, in spite of your all efforts, you couldn't survive. Never make a show to transfer patient to nearby ICU and to have some treatment at ICU and to declare patient dead at that ICU center. Because in this type of situation, it is a very common dictum. It is better to face case of negligence rather than case of forgery. Because once you shift dead patient, and if you are escorted, it's another story. But if you are straightway send patient to nearby center, naturally they will receive dead body. So now question will come. When you shifted patient, was patient alive? Or when you shifted patient, was patient dead? If dead, then why you shifted patient to that center will be very big question and you cannot justify. If she was alive, then did you try to resuscitate at your place? Because in one of the questions which was raised in Lok Sabha in 2014, and then Union Health Minister Dr. Harshvardhan had also answered that in this type of situation, whenever there is sudden cardiac arrest or whenever any emergency patient is brought to you, you have to stabilize patient, you have to resuscitate that very patient, and then only you can transfer patient to higher center. So all these points matters whenever you are facing litigation in this type of situation.
Sir, can FIR be directly launched against the doctor in this case? And can postmortem examination may help the doctor?
Yes, naturally, I just mentioned we should insist postmortem examination, because if we are sure of our cause of death, that is amniotic fluid embolism or so, postmortem examination will endorse our finding. So it is always better. And if we advise, it shows that our intention is very bona fide to know cause of death. If on patient party they advise, then of course it is always welcome step, but if we advise, it will be much better. And as far as question FIR, patient or patient party may lodge complaint against anybody. FIR can also be lodged, but when this FIR is lodged, straightway police cannot take action against doctor as per guideline given by Supreme Court in famous case of Jacob Matthews versus State of Punjab. So there should be some prima facie negligence on part of treating doctor. So police may investigate case. They may have a statement from doctor, statement from relative. They will collect all the papers of treatment given, and they may refer all these paper to nearby medical college respective department. And if there is opinion from respective medical college department that it seems to be prima facie negligence on part of treating doctor, then only further in this charging, framing of charge, etc. will be done, and this case will be put in court. Otherwise,
sir, we have two more questions, sir.
Yes.
And we have only 5 minutes left.
Okay.
Sir, for a short minute, actually, FIR cannot be filed against a doctor directly, because nowadays it is said that there is a establishment of medical board at every district level. Unless and until the medical board gives the clearance, they cannot file a FIR. Rather, they can file a complaint, but not an FIR.
I explained, na?
Right.
They will go with complaint.
Right.
Police will investigate. Police will refer to nearby medical college, whether it is medical board or head of the department of respective subject. Say for if it is a case of gynecology, they will refer to gynecology. If it is a case of surgeon. So, and when department gives opinion, and then only police will proceed further, whether FIR is to be lodged or whether the case is to be sent to the honorable court.
Thank you, sir.
Thank you, sir. Now we have Dr. Sonali Damkondwar, ma'am. She's been practicing for 19 years and she's the president of Hingoli Society. Over to you, ma'am.
Good evening, sir.
Yes, welcome.
Yes, ma'am. Good evening, sir.
Please go ahead.
Sir, my case is like this: Gravida 2, Para 1, Living 1, built with previous LSCS, had planned cesarean section. Now, intraoperative period was uneventful. No past significant medical history was there. Patient was planned for discharge on 4th post-operative day. And on 3rd post-operative day, patient was taken for dressing. Suddenly, patient collapses, became cyanosed. CPR was started, but could not be revived back. Cause of death, pulmonary embolism. How to deal with this situation, sir? Attendant started creating nuisance.
So attendant started creating nuisance. Same. You have to inform police. You have to inform professional colleague. If you have surgical, rush team in your society, then you have to inform 1 or 2 persons of rush team, and they will inform other people whosoever are available. They will be at your rescue. This type of same situation happened in city of Ahmedabad only just 6-8 months back, and that doctor informed 2 to 3 persons of rush team, because we have rescue team in each area, and that is big city. So in that very area, he had a phone call, and he phone called to me also. You won't believe, within 1 hour, 150 gynecologists were there at that very hospital. I informed police. Police came and we insisted to go for postmortem examination. Relative refused not to go for postmortem examination, and then burden of this to going for postmortem examination is on shoulder of police, because once you inform police, then that is between police and relative. So police informed magistrate. It was middle of night, and even then magistrate came, and relative gave statement before magistrate that they were not willing to go for postmortem examination. And they also gave a statement that they have no complaint against hospital or complaint against that very doctor. And in this case, our doctor was saved that way. So here comes importance of rusting. So whenever you are facing any problem in this type of situation, always call your professional colleague. And if you are expecting that there is something miscreant on part of relative, then you can inform police also.
Thank you very much, sir.
So we are now at the end. So we have Dr. Shraddha Paritkar, ma'am. She's studied from Nair Hospital and Nanavadi Hospital. She's the state representative, Aurangabad Obstetric Gynec Society, honorary secretary, Aurangabad Society in the past, and she loves social work.
Thank you so much, sir. Good evening, everyone. Thank you for including me in this panel. All the best for the upcoming election, sir, and ma'am, both of you. My question to you is, sir, can you please guide us against whom this medical legal complaint can be lodged and where can we lodge such complaint?
So against anybody, any service provider, complaint can be lodged. Again, gynecologists, against hospital staff, against receptionists, against pharmacists, whosoever are involved in management of patient, they can file a complaint. Radiologists, pathologists. So against anybody, they can lodge a complaint. And as far as where complaint can be lodged, it depends upon the patient and patient party. If they are interested in compensation, then they may go with a complaint either in civil court or in CPA. If they are interested to go for criminal complaint, then they may prefer complaint in police station or straightway in court. If they are interested to harass doctor other way also, then they may complain in medical council also. And they may complain at a time in Human Rights Commission, in government. If any complaint against government doctor, then they can complain in government about departmental inquiry and disciplinary action, etc. So they have all the options open to lodge complaint anywhere. But burden of proof is on the shoulder of prosecution to prove negligence, and it is very difficult to prove negligence against doctor if doctor has treated that very patient as per standard medical norms. Yes.
Any questions from anyone before we officially end the session? Thank you all respected panelists for being here. Though we have delayed the program by half an hour, but you're still here. Thank you. Thanks a lot for being here.
So before we end, it is humble appeal to vote for me for post of President Foxy. Consider my seniority, sincerity, dedication, and easily availability to assist any Foxian friends in any medical legal crisis. I am always there to guide, always there to assist. Please consider. And as far as election of Dr. Asha Jain Madam is concerned, she is for Chairperson, Food, Drug and Medical Surgical Equipment Committee. In this election, society will vote. So if society is big A category, they will have to 2 vote, and any other society will have 1 vote. So please vote for Asha Jain also. My election would be from 1st August to 10 August, mentioned by Asha prior also. And her election would be from 16 August to 25th August.
I thank all the 5 societies, all their office bearers, and all the members who have joined in. This has been one of our really successful programs. Thank you, Aurangabad, Hingoli, Jalna, Osmanabad, and Parbhani societies. Thank you, Vinayak sir and Dr. Dipti for scintillating talks. Thank you, M.C.Patel sir, for running the panel so well, and all the panelists for being here with us. Thank you, respected delegates, for making the program worthwhile. Thank you. Thank you so much.
And I would like to congratulate Dr. M.C.Patel sir and Dr. Asha Jain madam in advance for getting elected in their Foxy elections. We are with you.
Thank you, sir. Thank you, sir.
सगळे वोट पाहिजे.
Yes, sir.
Yes, sir.
Definitely.
Wishing you all the best, Asha ma'am and Patel sir. We are all with you. Thank you for the opportunity.
Thank you.
From all of us.
Thank you so much.
Thank you all the faculty members. I know I've been calling up everybody and pestering them.
No, that's really nice of you, Dr. Monica. Because of your persistence, I got
Thank you,
motivated
Monica.
again.
You actually made the program happen. Thank you so much.
Monica is good coordinator.
Yes.
Thank you so much.
Coordinates well.
Thank you.
Thank you so much,
So
sir.
with
Thank you for the
permission, may I
opportunity.
end the session, sir?
Yes, ma'am. Yes, sir. Good
Namaskar,
night, everybody.
Shubhratri.
Bye. Good night.
Thank you.
We are at 199 and next we are going to have 200.
Great.
Sure.
So stay
That's great.
tuned. Thank you.
Thank you, ma'am.